In the series of post-COVID complications, we are targeting oncosurgery. What we are able to conclude with this is to have different setups for different groups of disease or specialties. So, if one setup is overstressed or overburdened, it should not barge into functioning of the other specialties. We should have more of separate infectious disease hospitals, and the beds, OPDs, human resources should be properly distributed to the specialties according to the prevalence of the disease. Today, to discuss the scenario of oncosurgery in COVID times, we have Dr. Asit Arora, GI Onco Surgeon, with us. The discussion will be taken up by a renowned family physician, Dr. Pratik Banerjee. Over to you, Dr. Pratik Banerjee.
Good afternoon, Dr. Asit. Glad talking with you. Heard a lot from Dr. Diwakar regarding your specialty. As Dr. Diwakar has pushed across today a very complicated topic, GI tumors in relation to the COVID epidemic. Being a first-line exposure to COVID as a GP, I just want to know what the frequencies of GI tumors are in the COVID pandemic.
So if you look at the frequency of all the cancer, if you see top 5 cancers in India today, I think some of the most common cancers would be GI cancers, and commonest would be, I would say, carcinoma of colon and rectum, that is the large intestine, the carcinoma of the stomach, then would come carcinoma of the esophagus and pancreas. So they are one of the commonest cancers, not only across the world, but also in India. So COVID obviously will not impact cancers directly because, as you know, it's a viral illness. It is not an etiology for cancer, nor it will increase or reduce the incidence of cancer. But due to COVID, what has happened is that one, because of the most of our infrastructure has been taken over for the management of COVID, the long-term management of cancer has taken a big hit. So what is happening is, because of these COVID-related issues, because of the logistics issues of lockdown and other things, patients are not able to reach to the first line of care, the GPs and the physicians, where the cancer diagnosis usually happens. So what is happening is that we are detecting these cancers at the later stage. So we are diagnosing them at late, which reduces the potential of treatment and cure. So this is the impact of COVID on cancer care. This is making our cancer care more difficult, and this is impacting cancer care in a very negative way. That is, I think, how I would like to answer your first question.
Generally, histopathology point of view, what sort of cancer?
Most of the GI cancers, because they're arising from mucosa of the intestine, so most of them are adenocarcinomas. Colon, you see in colon and rectum, so most of them are arising out of the mucosa of the intestine. That is a adenocarcinoma. In gallbladder, majority are adenocarcinoma. In pancreas, it is arising from the duct of the pancreas, which we call as ductal adenocarcinoma. So is for the stomach. Most of the cancers in stomach are adenocarcinomas. But in esophagus, the upper part of esophagus, since it is lined by squamous epithelium, most of the cancers are squamous carcinomas. But in lower end of esophagus, you have more of adenocarcinomas. So that is the spectrum. So most of the GI cancers are adenocarcinomas, but most of the esophageal cancers are squamous cell carcinomas.
Thank you for this information. This is a very important information. Can you just tell me one thing? In the malignancy, which one would be more dangerous, the squamous cell carcinoma or the adenocarcinoma of the GI tract?
No, again, sir, this is probably, we'll have to paraphrase this. It will all depend upon the organ of the origin and the stage that we detect. The histology per se is just one part of the entire spectrum. So if any malignancy, if it is arising out of pancreas, now pancreas can have different malignancies. Most lethal of pancreatic cancer would be adenocarcinoma, the ductal adenocarcinoma, the so-called pancreatic cancer as we know of. But pancreas can have very indolent tumors also, say the neuroendocrine tumors. They are also a very common pancreatic cancers, but they are not as aggressive as pancreatic ductal adenocarcinomas. Similarly, if you say colon cancer will never have squamous cell carcinoma. That histology is very, very rare. So usually you would not encounter it. Similarly, in esophagus, again, only the histology won't matter much. It will all depend upon what is the site, whether it is arising from the upper esophagus or the middle esophagus or the lower esophagus. Then more importantly, what is the stage at which we have diagnosed it? And thirdly, what is the basic underlying health status of the patient, whether it will allow us to treat it in more optimal manner or we'll have to, give our therapy in more fragmented manner. So we'll have to look at the entire spectrum, not just the histology per se.
If the person has been diagnosed a cancer of the GI tract, would just like to know what would be the duration of the from the time of diagnosis till the time he hits surgery.
So, that's a very important point that you have brought. I'm glad you brought this out. For all GI cancers, so these are all solid organ cancers. Yeah. So as a rule of thumb, the solid organ cancers, the only potentially curative option. So let me clarify this again. Only potentially curative option. The only way we can cure these patients of solid organ cancers is if you can operate them and achieve curative surgery. All other treatment options are palliative. None of them can cure. Chemotherapy can't cure a GI cancer. Radiation cannot cure a GI cancer. It is only surgery that can cure a GI cancer. So this is the one point that I want to emphasize. So whether we can operate a patient or not depends upon the stage that we have diagnosed. Unfortunately, if patient come to us in the late stage, in stage 4 or in the late stage 3, where cancer has evolved into very other critical organs alongside the tumor, then we cannot operate it. In those scenarios, we'll have to either resort to palliative chemotherapy, or in some circumstances, and nowadays, we do something called as neoadjuvant. That means we downstage the tumor and then take them up for surgery. So still, surgery is the soul of the treatment of all GI cancers, be it the esophageal cancer, be it the colon cancer, be it the liver cancer, be it the stomach cancer, be it the pancreatic cancer. Soul of the surgery, soul of the treatment is surgery. Whether we can operate on them or not depends upon the stage. So I'm considering that we are talking about a cancer which is operable, and we are trying to treat them with intention to cure. Patient, they should be operated at the first given opportunity. That means when our patient is optimal, when they have been optimized enough to undergo surgery at the first given opportunity in the safest environment. So they should be operated as early as possible.
Okay. Dr. Sab just wanted to know that what is the time period between cancer moving from the first to the second, third or fourth stages? Is there a time period? And
so unfortunately, there is no fixed time frame. How would tumor multiply? So there is basically something called as tumor doubling time. Okay, right? So if just imagine that there was a tumor which started with one cell, then it will divide into two, then it will divide into four, then eight, then 16, then 32. So it is following a log. As time goes on increasing, the number of cells that is being added with every division is just increasing exponentially. More you wait, less is the doubling time. Trick here is that we have to detect cancer as soon as possible and start treatment as early as possible. So more you delay, the more harm you. So it should not be delayed at any time point, neither at the time of first diagnosis, nor at the time of referral, least at the time of once it has been referred from there to initiation of therapy. So we should all be in a same, I would say the same tangent, that we have to diagnose the patient at the earliest given opportunity, the first opportunity, and refer the patient at the first given opportunity, and treatment should be started as soon as possible.
Thank you very much, Dr. Arora. It's been a very pleasant information transfer to all the GPs and doctors. I think this is a takeaway home message from you. Thank you very much, Dr. Sir.
Thank you so much, sir. Pleasure was all mine. And thank you so much. Thank you, Dr. Diwakar, and thank you, Dr. Banerjee, for having me. Pleasure.